So today I'm going to be talking about a couple of Q&A items. I got a question about somebody who has a stage 3 melanoma, got immunotherapy first with Keytruda for about 6 months. Then it was changed to the dabrafenib and trametinib, and then another month of Keytruda again, probably due to side effects. I would believe that, or I would assume that, to change from Keytruda to the dabrafenib and trametinib, which is targeted therapy, most likely the person might have had side effects. And then even after a year from treatment and after everything is finished, still skin rash is a problem. So here I have a couple of points about the skin rash in the setting of melanoma treatments. A skin rash that lasts 1 year after treatment is most likely due to immunotherapy. We know that the immunotherapy can cause side effects, and those side effects can be sometimes more kind of like chronic. So a skin rash that is still there after 1 year of completing immunotherapy or completing melanoma treatment, in this case immunotherapy, Keytruda, and targeted therapy, is most likely absolutely due to immunotherapy, not targeted therapy. The pills, although commonly can cause skin rash, however, the skin rash goes away after you stop the pills, while immunotherapy rash is more kind of like more chronic rash. And the rash or the skin manifestation that I have seen in the people I see here in the clinic can be just a little bit of skin rash, could be more disseminated rash. It could be a rash with itching. It could be itching alone without rash. It could be just a skin rash and it's a minor few pimples or papules here in the, we see it in the chest area, we see it in the extremities, and it's not a big deal. It doesn't bother the person, so we don't worry about it. We try to manage all the skin rash if we can with local treatment, such as creams, hydrocortisone creams. If we're going to apply Benadryl creams, moisturizing cream, we try to do local therapy. In some cases, sometimes people, because of the itching, they require some anti-itch medication, whether it's Benadryl or hydroxyzine orally to help with the itch. We try to avoid using oral steroids if we can, but in certain circumstances, we have to use oral steroids sometimes for a short course if the skin rash is really, really bad, and try to see if it goes away. And if it's for people with the skin rash is not going away and they're like having a lot of itch, sometimes we put them on a small dose of steroid like prednisone, 5 or 10 milligram, just to help them a little bit with this chronic, annoying side effect. Again, we try to do the prednisone if it is really severe and it's affecting the quality of life of the patient. Otherwise, we try local treatments. We also use our oncodermatologist here in our center. They can help us a lot getting a biopsy and trying to identify, exactly what it is and try to appropriately treat it. So we're fortunate to have oncodermatologists here in our cancer center that can help with the side effect or skin side effects from the treatments we give. But I agree with the question asked. Skin rash can be chronic. I've got people, even they say 3 months we're doing fine, and all of a sudden a wave of skin rash comes. So definitely it's a side effect from immunotherapy. The other question has to deal with the radiation therapy. When do we use radiation therapy on melanoma? In melanoma, I'll give certain scenarios where I could refer the patient that I'm seeing to a radiation oncologist. And these are the scenarios. For example, if a patient had a brain tumor that was removed, then they would require radiation therapy, the tumor bed. Or the area where the tumor was, we need to radiate that area. That's one. Let's say a person had a stage 3 melanoma and underwent clinically stage 3 melanoma, meaning the lymph node were detected on a scan, or the person presents with a large lymph nodes that he or she could feel, then the surgeon tell them, well, we're going to do a lymph node dissection. After the lymph node dissection is done, we read the pathology report, and if there is a phrase called extranodal extension, that means tumor trying to get out of the lymph node, we send these people also to radiation oncology to discuss local radiation to the lymph node area. We don't do the radiation after sentinel lymph node biopsy. It's only after lymph node dissection, and only after the pathology said there is extranodal extension. Then I think it's worth a trip to a radiation oncologist to discuss. Radiation therapy decreases the risk of local recurrence, but it does not improve the survival. So that's another point. The third scenario that I can think about it, somebody with stage 4 melanoma, we're getting immunotherapy, but they're having this severe area of pain, a lot of pain, whether it's in the hip or in the spine or in the bone. And sometimes we definitely refer them to radiation therapy. We call it palliative radiation, just deliver some radiation to that area to help with the pain. Another scenario is malignant melanoma to the brain, where you have those small spots. Always we treat with radiation, with immunotherapy. Yervoy and Opdivo is the standard of care of melanoma to the brain, but sometimes immunotherapy doesn't work, and we try target therapy. It may work for a while and then stops working, and if the person has few spots, always we can definitely do SBRT, or what we call it stereotactic body radiation therapy, or another modality, we call it gamma knife. So we can definitely send them to radiation oncologists to get evaluated for that. And finally, somebody with a spinal cord compression, a mass or tumor on the spine that's pushing on the spinal cord, and they have weakness in the lower extremity. Sometimes the surgeons will take them to surgery to do debulking surgery, meaning removing the tumor. And after removing the tumor, also these people would require radiation therapy after the surgery. So these are some scenarios where I can, think on the top of my head about where to use radiation therapy in the setting of melanoma. Probably also somebody with stage 4 melanoma that we're doing immunotherapy and it's not working, but he has few spots in the body. Certainly we can target 1 or 2 spots and to see even if the radiation therapy might help enhance the efficacy of immunotherapy. So these are the modalities where radiation therapy can be used in the management of melanoma.